So my name is Dr. Cole, or Chelsea Cole. I did my family medicine residency at UT Southwestern, and then I just completed back in August my sports medicine fellowship at LSU at the Lafayette campus, working with the Ragin' Cajuns up there. So that's kind of my background of what I did. So one of the things, overview of kind of sports medicine. So sports medicine, obviously a branch of family medicine, or that's kind of where it started. It's now, you can get into sports medicine from a lot of different fields now, because it's an area of medicine that's grown significantly over the last 10 years. But it's usually going to deal with like physical fitness, prevention and treatment of acute and chronic illnesses, not just related to specifically sports, but also often a lot of the patients we see are patients who had a history in sports. And so they have some of these acute injuries, and it's kind of helping them continue to be active later on in their lives when they're not football players or basketball players doing things in college sports or anything like that. So patients obviously range from pediatric to the geriatric population. And the other thing about it to remember with sports is that a lot of younger people who go really hard and do a lot of not just our athletes, but also do a lot of outside activities and things like that, they're going to be more likely to have those kind of injuries where they broke something or something like that and have arthritis and some other things happen. So a lot of it is your older athletes or your older weekend warriors or your older active people. Sports medicine is a 1-year fellowship. So usually you can enter it through family medicine, pediatrics, internal medicine, emergency, and PM&R. One of the things to note is that family medicine is one of the easier specialties to get into it, because not all fellowships take every single specialty, because you actually have to have a person on staff that is that specialty to be able to take a fellow in that area. So usually, and PM&R is becoming more, but there are a lot less fellowships that are PM&R oriented or take PM&R residents versus family, because almost all fellowships take family because they were originally family medicine trained. So they're kind of based in that. So typical conditions and kind of things we see. So traumatic injuries such as fractures, ligament injuries, sprains and strains. Sometimes you'll be the first person to see them. Sometimes they'll be referred from the ER. Sometimes you'll see them on the sidelines. Overuse injuries are really common. Most, especially in runners and things that people do a significant number of miles. There's also a lot of overuse injuries in golfing, which I didn't really think about until I got into sports, but because people start golfing usually at a later age, and you're not running, you're not doing anything super physical or intense, you can golf for 30 or 40 years. So you can get a lot of overuse injuries from that kind of thing. Same thing with tennis and other stuff like that. Pediatric conditions such as Osgood-Schlatter, Seaver's disease, things like that are related to growth and development. And then, functional injuries such as people's having issues with their running gait or with throwing or with ways they're rock climbing and things like that, and kind of helping them. Sometimes it's somebody gets an overuse injury because they functionally aren't performing the way that they should. And so that's another thing. So chronic conditions, arthritis is always going to be a huge part of any kind of sports medicine practice, because that is a huge part of shoulder pain, knee pain, back pain, all that kind of stuff. And obviously chronic conditions are going to age with your patients. And then things like acute tendonitis, tendinosis of various joints. And then the big thing with sports is kind of unlike other areas, not that other areas of medicine don't want people to be active, but one of your things is that you go around and do things a little bit differently than you would in other fields, because your thing is trying to keep people as active as they want to be as long as possible. Not necessarily trying to limit them or tell them this is the type of activity you should do, because you'll have patients come in, will say, this is what I do. And you look at them, you're like, how is that a thing that you do with your knees looking like that or whatever? But the point is to help them kind of get through that and be safe and be able to continue to be active for as long as they want to be. So it's one of the things about sports medicine is that generally you have a pretty motivated patient population, because they're usually coming to you because they want to seek out some sort of active treatment. So it's a little bit different than other fields in that respect, is that you do have that motivated patient population, which is nice when you're treating people when they kind of have buy-in already. So different types of practices. So there's some people that work in kind of a mixed combination, family medicine, and they see sports medicine. Sometimes they'll have like sports medicine days where they do procedures and days where they see regular family medicine. And then there are some people that work specifically 100% sports medicine. So if you're doing that, you're going to be doing like non-operative procedures, fractures, treating people who have been referred to you by their primary care or some other specialty to kind of further evaluate an injury or something that's going on. Another big area that people work in is they will be the primary care sports medicine person in a large orthopedic practice. So one of the graduates from our practice works up in Arlington, and there's 2 different practices that she works out of, and she's the primary care sports medicine person in like a group that has a hand surgeon and an orthopedic like joint and shoulder surgeon, stuff like that. So when they are being like initially seen, or they have fractures that don't need to be operative, they can be handled non-operative, or she does a lot of procedures and stuff, because a lot of times in a practice with orthopedic surgeons want to do what they were trained for. They want to do surgery. And so a lot of times if it's going to be a procedure or something, especially with ultrasound, because a lot of ultrasound has become a very big thing in sports medicine. And so everybody who's coming into the field now is trained in ultrasound. And if you've been somebody in practice, if you've been an orthopedic surgeon for 30 years, you don't necessarily want to relearn how to do ultrasound. So you can have somebody join your practice. And there are people I know somebody who graduated from my fellowship who literally works up, I think it's about an hour outside of Chicago, and just does ultrasound procedures all day, every day. He works for a big group, which if you like that sort of thing can be very lucrative. And if you like doing that if you love doing ultrasound procedures, can be something that is very rewarding, and he makes a good amount of money doing what he does. There's also team physicians. When you get up, there's not really any like level where you're usually like just a team physician. Even team, in a NFL level or NHL or any of the pro sports, usually those people have their own practices, but they cover. And usually it's a large group of people that cover. But team physicians can range, from grade school to professional sports. There are a lot of people, and you can also cover team sports. Like you can be the team doctor for a high school football team or a high school, lacrosse team or whatever, soccer, whatever you want to do. Those are things that you can do if you're interested in sports. You don't have to be sports medicine trained to do that sort of thing, but lots of family medicine physicians will go in and do that as kind of a community outreach and a way to kind of keep in their community and a way to kind of get patients and families into their practice. So that's usually not like your one job. You usually do that as a conglomerate with everything else that you do. And then academic sports medicine. So that's what I do. And like I said, just graduated from fellowship. So I'm back at my family medicine residency. I'm the sports medicine person, and we're in the process of working with PM&R to start a fellowship. So that's kind of right now, I'm kind of family medicine and I'm doing inpatient and outpatient, and I'm starting to build up my sports medicine practice. And over the next couple of years, I'll transition to being more like a faculty within a sports medicine fellowship. So that's kind of that's where I am. So some people work in fellowship, some people work as the MSK person within a family medicine program, because that is something that's very important, because a large percentage of the people that you see in family medicine come in with MSK complaints as their very first thing. So even if you don't go into sports medicine, you need to be comfortable in a family medicine practice with dealing with MSK, because you're going to be the first person to see them. So you need to know what you're looking for. So things about sports medicine candidates. So one of the things to note of the fellowships that you can go into out of family medicine, sports is one of the more competitive ones. Because there's so many different areas that kind of are vying for spots, and there's like 120, 100, and I can't remember the exact number. There's many sports medicine fellowships, but most of them take 1 or 2 fellows. So that's not a ton of spots. And there's a significant number of people who apply to sports medicine each year who do not get a fellowship spot. because there's way more applicants than there is spots. So one of the the area of interest things that you do to kind of make yourself a better sports medicine candidate when you decide that that's something you want to do is obviously early on you want to sit down and kind of talk to whoever is in your family medicine residency or in your internal medicine residency, whichever residency you're in. And one of those things is if you two decide that it's something that you want to do, you want to kind of identify that as something you're interested in earlier, sooner rather than later. You don't want to wait till the end of second year to kind of do it. So if you do go into residency and you think it's something that you want to do some stuff to kind of make yourself look interested throughout the several years. Because if you wait until the end of second year, you just don't have enough time to get the stuff together for fellowship. So even if you decide you don't want to do it, if you're interested in it, something you should like identify someone in your residency and that you should let them know that it's something you want to do and kind of work towards doing some sports medicine activities. So just like when you go into residency, really one of the biggest things that fellowships and residencies are looking at is, are you interested in that specialty? Do they look at your application? Do they talk to you? Do you actually want to do it? Because the last thing they want to do is bring someone into their fellowship or bring someone into the residency that doesn't actually want to do that thing. So that's one thing. So they're looking to see, do you have event coverage? Do you have sports coverage? Have you done rotations with sports medicine doctors? Have you, attended conferences or meetings related to sports? So lots of times they'll recommend you join AMSSM, which is American Medical Society of Sports Medicine, or AOSM or other sports societies, and go to meetings and have that be something that you look like you're interested. And if you are interested, you should want to go to those things. They're great. You guys know you've been to conferences and other things like that. If it's the area that you're interested in, there's it's very fun and informative to be with a bunch of other colleagues that are kind of in your field and all kind of want to talk about the same stuff. And the other thing is that they just want you to look like a strong candidate because it is competitive. So leadership is not a requirement, but lots of times people run for chief or run other sorts of clubs or other things like that. So they have that on their CV, because that's one of the things that makes you look, it always, if you're, coming up against somebody who has all the same qualifications as you and you have a leadership role, you have something else, it just kind of makes you look like somebody, or it makes you not just look, but it makes you look like you are just more competitive and more kind of out there and kind of willing to go the extra mile. And that's something that they want. And then another thing is good board scores. So one of the big things about sports medicine that you learn is that the boards for sports medicine are difficult. And I don't say that just because I'm a sports medicine doctor and it was hard. Usually with family medicine, most people, the first time pass rate is in the 99. It's like 99% of people first time pass. And with the sports medicine boards, I think 2 years ago is the last one they have, it's like 80%. It's like 80 or 2%, which means people go and do fellowship and they take this test and like 20% of people do not pass. So it's something that you can do, but you do have to start studying, you have to start early. And it's a lot of information to learn in a year, but fellowship is always, just like when you get into residency, it's fun to be able to focus and do what you want to do. It's even when you go into fellowship, it's a really good experience but it's also very overwhelming at first because every single thing they teach you is something you want to remember, because this is your specialty. This is what you want to do forever. So nothing can fall through the cracks. You can't just be like, oh, that rotation is pointless because that rotation is there because you need to know it for your job. So, but it's a good experience, but it's one of the things is that they will look for good board scores because they know that if you can't pass boards or pass other things, that it may be a problem. And another thing that residencies and fellowships don't want is they don't want somebody who they're going to worry isn't going to pass, because those pass rates, as you know, for those things they want to be able to say they have 100% pass rate. They want everybody to pass. They also want you to succeed. So they don't want you to not be able to qualify and go through and work in your field. So the other thing, so fellowships usually start in July or August. Most of them start in July. The one that I did started in August, and a couple of them start in August. And some of that is because orthopedic fellowships and orthopedic, so they don't take family medicine takes their boards during April. And so we take it during actual residency, which I believe we're the only specialties that does that. A lot of them take it in like July or something in between. So some of the fellowships rotate because you work with ortho fellows and work with orthopedics. They'll start in August to kind of delay to be on that same schedule as them. So that's not something that you would like pick a fellowship for. It was nice to have a month off in between, but it doesn't happen for everyone. And it wouldn't be a reason that you'd go somewhere. So things that you do in fellowship, they're going to be kind of all across. You'll usually have a primary care sports clinic that you work out of. You'll usually also rotate with various orthopedic specialists to kind of see, and orthopedic surgeons to see kind of what they do, their exams, their techniques. Some of it is learning good things to do. Some of it is learning a way that you don't want to do something. And you do that all the time in medical school too. Like some people you rotate with, you pick up on positive things, and some people you see do things that you're like, I don't want to do that ever. So that's just kind of what happens. And that's part of learning your kind of your technique and your skills. You do OR time. They do have you, not a ton of OR time, but you do go into the OR. It's one of those things where it's nice to see the anatomy when like the skin and everything is taken off, especially once you get to that level where you understand it more. And they want you to be able to talk to your patients about like what kind of procedure you want to do. So some of it is just like you being able to educate, like this is the next step we're going to do. This is kind of giving them kind of a send off of what they're going to do, instead of when you have a patient who needs surgery, they just ask you questions and you stare blankly at them, because patients, you're usually the person they see more frequently than the specialist they're going to. So they trust you a little bit more. So if you have the answers to those questions, it helps better. You'll also work with athletic trainers and athletes in various different settings. Like I said, it's all the way from in fellowship, everyone who goes into fellowship has their kind of high school team that they cover. So you'll be like the team physician for the high school. And then depending on where you go, you'll cover various other sports. At our fellowship, we each had a high school team, and then we covered all of the college's sports. It was a D1 school, but it was a smaller D1 school, but we covered volleyball, women's soccer, men's and women's basketball, softball, baseball, football. So it was a lot of coverage, but also you just get to, I mean, part of your job is you get to go get paid and watch games. So it's really not that bad. So you do all the different like sideline coverage. And then it's pretty much across the board at this point. You'll have ultrasound training in diagnosis and in procedures. And so every place will be different as far as what they train you in. But like for us, we had a course from basically a specialist in MSK radiology who came and taught us all the basics. And then we got together with another fellowship and did procedures and stuff together. So there's usually some sort of ultrasound in there. And then you'll often also work with sports nutrition and sports psychology, because that's also something that's coming way more to the forefront of sports medicine, is that a lot of these athletes and different people that are, going to college, doing full-time, like regular, they have a second job and they are put under a lot of pressure. And so we've recently come to realize by doing several different studies and things that in our athletic population, the rates of depression and anxiety are similar to the general population, except that they're not really allowed to kind of be depressed or anxious, except they're like constantly in a high pressure situation. So we see, when I was in fellowship, we treated tons of people who had depression and anxiety that like hadn't started having it until they got into these sports, and they have such high standards for themselves. Not that everybody doesn't, but like it is something that it's kind of it's not really it's getting more well received within sports medicine, but it's something that like, if you think about coaching and situations with like teams and stuff, it's not necessarily something that has always been widely received as being an issue. One of the other things is a lot of places you'll do coverage at a ski resort. Mine didn't, but a lot of them do, which is great. You usually go and you'll work at a ski resort with a doctor and get to see like acute fractures and everything like that, like right on the field. So that's a really, really big thing that's really great at a lot of different places. And then studying, there's lots of studying. They kind of tell you from day one that you need to start studying. So, but you've already studied, you know what to do. It's not a daunting thing. So I think a couple of the questions that were asked was, one of the questions was about kind of where are the lines between MDs and physical therapists. So you'll realize in the sports medicine world, um, some of those lines kind of blur depending on where you are. So when you are on like a college, like you're working with like a college team or even a high school football team that has an athletic trainer, that athletic trainer is there every single day, all the time with them. So they are trained. I mean, they have significant training in like how to deal with kind of some routine, kind of even medical stuff. And they know which of their kids has asthma and which of their kids overreacts and which of their kids, you know, I mean, they know everything about these kids. They're in and out because they're with them all the time. And so a lot of times you work hand in hand with them, but like there is a boundary that like if they will come to you when they need you, and they know when they need a doctor, or they know when they need a second opinion, or they know when they need something else to happen. And so it's a very collegiate role. It's not something where there's one versus the other. And the same thing with physical therapy. Physical therapy, when you're in sports medicine, are kind of your best friends. They're your best go-to, because you can tell, you can like come up with protocols and things and stuff to do in rehab, but like they're gonna take your diagnosis and see that patient and kind of help them work through how to make that better. You're not gonna go through and help them do rehab on their tendinosis or their tendonitis or their shoulder injury, because that's not what you're there for. You have to trust your physical therapist, and you have to find people that you can rely on, because it's not a us versus them. It's everybody together. They're all our patients. Sports medicine has become much more of kind of a team effort, and that you have several different specialists and everybody has a different way they look at things. And so you want to work with them in the same way that when we have a patient, you send your patient to the gastroenterologist or the cardiologist, and you're kind of working together in different respects. So trust that other people have like their different areas of expertise, and they're trained differently than you. And there's more than one way to look at a problem. And so they have a little different way to look at it. And then as far as like sports med physicians compared to PM&R ortho, so ortho generally will do surgical things, like surgical procedures. Lots of orthopedic surgeons do injections and things like that, but often they aren't going to treat a like non-operative problem. So often sports medicine is like the first person that somebody gets sent to, and then you may send them to the orthopedic surgeon. Sports medicine and ortho works really well together, because if you have a good sports medicine relationship and you have a good relationship with your orthopedic surgeon, they like it because you send them people who have already done all of the things. You've tried everything and they need surgery, instead of somebody sending them who doesn't know how to kind of start that process, and they come in and they have arthritis and they've never like done anything. They've never taken an NSAID or anything like that. An orthopedic surgeon doesn't want to see that. That doesn't need to happen. And there are lots of people that aren't appropriate for surgery. So that's one of the things, is you can do the non-operative, and you learn in fellowship and through your training when somebody needs to go to surgery. And so you can properly refer someone to orthopedics. PM&R, so PM&R is very MSK focused as well, and rehab focused. Lots of people who like at UT Southwestern in the sports medicine realm, several of the physicians are PM&R, but they're sports medicine trained. So you're trained kind of the same way. A lot of PM&R, there are fellowships that have PM&R and they have family medicine, and you obviously have a little bit different background of where you come to things, where they have a lot more experience with rehab and that kind of aspect of things. Family medicine has a lot more of a primary care aspect of things. So you work together, but you both, when you do sports, you do kind of the same thing. So you end up being a sports medicine doctor in certain fields. But a lot of times people will have like I said, have a kind of a co-practice where you'll see like family medicine. A lot of times they'll see PM&R and do some sports stuff. So they're not really mutually exclusive. Once you get into sports medicine, they're trained in the same kind of manner that we are. They go to the same fellowships and everything. And then the other question was, is there any benefit in doing a sports medicine fellowship and then having a normal practice? So I mean, there is if you want to see a lot of sports medicine patients and if you want to do procedures. So it really depends on how you want to build your practice. There are people who go through and do feel completely comfortable doing injections, or they go to a residency where they get really intense ultrasound training and they feel comfortable with doing that sort of thing. If you want to have a practice where you see family medicine, but you also want to be able, to diagnose and treat and have sports medicine days or do more ultrasound guided procedures or treat more like non-operative fractures, it can be beneficial to do a fellowship with it. You just have to kind of look at like what you want your practice to be and look at kind of your long-term whether you want more training in that area or whether it makes more sense for you to just go into your field and kind of try to build some sports medicine in. It does, because it's becoming a larger field, having that extra qualification, the CAQSM, is very helpful when you're in larger places like Dallas or places where it's kind of saturated. If you're going to, if you're going, to a place that's, I remember talking to somebody who works in a family medicine practice. I think it was in Midland, and they were like, "Oh, you don't need to do a sports medicine fellowship," because they did team coverage and did all the things they did. When you're in a smaller community like that and you identify yourself as a sports medicine person, you can get word of mouth and get that kind of thing. When you're in a large community like Dallas, people are looking for that like sports medicine qualification. So it really depends on where you decide you're going to kind of practice and what you want, whether you need that to kind of boost as far as like bring patients to you and make your practice the way you want. So, anybody have questions?